All right. Hello, everyone. My name is Michelle Whebe. I'm a medical student enrolled in the imaging elective at Fort Collins, and I'm here to talk to you about a case of a surgical resection of a paraganglioma. So we'll talk through the case, and then we'll also take a look at the patient's imaging in VR. All right. So starting off with just an overview of the case and some background information. So we have a 41-year-old female who presented with the right retroperitoneal mass adjacent to the kidney. This mass was actually identified incidentally. So the patient had some unrelated back pain, and they were undergoing workup for that pain at the Cheyenne VA. As part of that workup, they received a CT scan. So this is actually an image from that CT scan that they received at the VA. And you can start to see here that near the liver, there's this right upper quadrant mass that was appreciated. At the time, the patient denied any new medical concerns or other symptoms besides their known medical history and the back pain they were being worked up for. So, clinically, there was really nothing to suggest that they might have a mass of this size. At the time, the differential diagnoses included a duodenal cyst, lymphangioma, and a cystic neoplasm. As a first step in the workup of this mass, the patient was referred to GI for an ultrasound-guided fine needle aspiration. All right. So in terms of the patient's history, so their past medical history is notable for some hypertension in the past. They have GERD, seasonal allergies, and some chronic back pain. Their family history is notable for a fairly extensive history of cancer on the maternal side. So that includes breast cancer, liver cancer, gastric cancer, and cervical cancer. In the patient's surgical history, they've had a myomectomy for some uterine fibroids, and they've had a wisdom tooth extraction. They are currently on cetirizine for seasonal allergies. They have a Mirena IUD, and they take omeprazole. And then in terms of their social history, so this patient is a full-time active duty member with the Air Force. She exercises 5 to 6 times a week. She's never been a smoker, and she doesn't currently use alcohol. Upon initial physical exam, things are pretty unremarkable. So despite having some hypertension noted in her past medical history, the patient's blood pressure comes in at 130/80, so not elevated. On physical exam, things are also unremarkable. So the patient has a regular rate and rhythm upon auscultation of the heart. Their pulmonary exam it shows no notable findings. They don't have any abdominal distension. The abdomen is soft. There's no mass appreciated and no tenderness. Their skin is warm and dry. And then there's nothing notable on neuro exam as well. All right. So patient goes for ultrasound and fine needle aspiration. And I've actually pulled some images from this procedure. So you can see on the left where on ultrasound we've identified the retroperitoneal mass. Here it's measuring about 4.5 to 5 centimeters. And then on the right, you can actually see, if you look near where the yellow arrow is, where we have that needle going in for this biopsy. So initial pathology comes back from the biopsy, and it's noted that the findings are consistent with a paraganglioma. Upon assessment, the pathology team finds that the sample is positive for synaptophysin. So this is found in synaptic vesicles in the CNS and also in neuroendocrine cells. It's also positive for chromogranin, and this is a protein that's secreted by neuroendocrine cells. And then finally, it's positive for vimentin, and so this is an intermediate filament that's a marker for mesenchymal tumors. All right, so we have findings that say this is consistent with a paraganglioma, but what exactly is a paraganglioma? Well, it's a rare catecholamine-producing tumor, and it originates from chromaffin cells of autonomic ganglia. It's notable that by definition, paragangliomas are extraadrenal. So if they originate from the adrenal medulla specifically, then they're considered a pheochromocytoma. It's also worth noting that These tumors, more often PHIOs, are associated with germline mutations. So these are going to be things like your MEN2A, MEN2B, NF1, and VHL. So these are those hereditary cancer syndromes. In terms of the clinical features that we see, so patients will present with episodic or persistent hypertension. You might recall that our patient had some past medical history of hypertension, but they were relatively normal in clinic. It is possible that, with their high level of physical fitness, that even though they were within the normal range on evaluation, that maybe they were a bit elevated relative to their baseline. Otherwise, in patients, we tend to see things like paroxysmal headaches, diaphoresis, heart palpitations, tachycardia, pallor, abdominal pain and nausea, anxiety, and weight loss. And so our patient didn't demonstrate any of these symptoms, but you can appreciate how in looking through these common clinical features, these are all things that you would expect if you had an excess of catecholamines and an excess of sympathetic activation. All right. So after our biopsy comes back, what's next? Well, our patient was referred to a multidisciplinary GI tumor board for further evaluation of this mass. And it was the tumor board's consensus that the patient should move forward with additional imaging. So up until this point, we really just have the ultrasound, and then we have the external CT from the VA. Tumor board also recommended obtaining plasma or urine metanephrines, which are highly sensitive for a paraganglioma or pheochromocytoma. And then it was recommended that the patient move forward with a surgical resection so long as everything looked okay on imaging. All right, so let's talk now about that imaging. So the patient received a CT of the abdomen and pelvis with contrast, and I'm actually going to pull this image up here in VR. So I've already started to window a little bit, and you might recognize this view from what we saw earlier as well. So you can see here, starting off, we have the liver, and immediately adjacent to the liver, we have our tumor. You can see how the medial edge of the tumor is pushing up against the IVC, and how the inferior border is right up against the kidney right here. If I window a little bit more, you can start to see how in front of the tumor we have bowel and duodenum. And then going back a bit more, you can really see how we're right up against the IVC here. Another view that I think is helpful is actually changing the color scheme. And so for me, at least when I do that, it just gives me another view of these margins. It also, for me, highlights the differences within the tumor itself in terms of the consistency. And so we saw this on the radiology report as well, is that this tumor was noted as having kind of an internal cystic density. And so I think that's easier to see when we use these colors. All right, so next I'm going to go back to grayscale. And then another view that I think is helpful is looking at this from the top down. Because again, we're interested in the adjacent structures as part of the surgical planning process. So if I window in this direction till we hit our mass, and then pull back here a little bit too. So I think here you can also get an appreciation. So our tumor is sitting right here. We've got the kidney immediately adjacent. We have the liver here, and then we have IVC as well. And so let me just show you as we kind of scroll through again. You can really see how close we are to all of the vasculature and to those organs. Okay, let's put this aside, come back to our case. Okay, So we have our imaging now, and we're able to move forward with some pre-op planning. In the meantime, our metanephrine testing comes back, and it is positive, so further supporting this diagnosis of a paraganglioma. And a multidisciplinary surgical team is put together, and this includes a surgical oncologist. It also includes a vascular surgeon, because you'll recall when we looked at the imaging, we were right up against the IVC and also the right renal vasculature. Also, as part of the pre-op process, this patient is started on a non-selective alpha blocker, phenoxybenzamine, and this is done in order to help control the blood pressure and also to encourage blood volume expansion prior to surgery. So this reduces the risk of severe hypotension once that tumor is removed and we've taken away those excess catecholamines. A beta blocker is also added, but it's important to note that it's added only after the alpha blockade is achieved. So the beta blocker is added to prevent reflex tachycardia, and we would never start this before the alpha blocker. The reason why is because if we did, we could have unopposed alpha stimulation, and that could lead to severe vasoconstriction and a hypertensive crisis. So in terms of the surgery itself, this was conducted as an XLAP, so open surgery case. And the right-sided retroperitoneal mass that we saw was fully resected. It ended up measuring about 6 centimeters. It was noted to have some vasculature entering into the tumor. Also, it was directly adjacent to the adrenal, but important to note that it didn't appear to originate directly from the adrenal. So again, this is favoring paraganglioma over a pheo, because you might recall that a pheo would actually originate directly from the adrenal itself. All right, so our final pathology comes back, and it really just confirms our diagnosis. So again, the tumor is positive for chromogranin and synaptophysin, and it's noted that there are clean margins and that this is a paraganglioma. All right, so surgery was largely successful, but where does our patient go from here? Well, it's actually been over a year since the patient's surgery. They've had follow-up imaging, and there have been no signs of recurrence. They did also undergo genetic testing, and that did not show any pathologic mutations. So we didn't identify any familial cancer syndromes, despite their extensive family history of cancer. There were several variants of unknown significance, but these don't allow us to point to anything definitive that could have contributed to or caused the patient's tumor to occur. From here, the patient will need to continue annual surveillance for at least 10 years to ensure that there's no recurrence or new tumors. All right. Thank you so much for your time. Hopefully you found the anatomy interesting and learned something new about paragangliomas.